Hi class, we're on week 7 of our course and we are almost done. Very exciting things. I wanted to discuss right now, we're going to talk about substance abuse disorders and sexual dysfunction and paraphilic problems, disorders. Um, we are reaching the end of our course. I will probably do a separate video on the capstone just to help everyone with any questions or to enlighten anyone on any concerns. I am going to remove the discussion board for week 8 and the live lecture so you can focus on completing your capstones. I am fully aware that my course is not the only capstone, which I know is very stressful when you're trying to wrap everything up at the end of the year or the semester. So just be aware those are things that I'm doing for week 7. So let's talk about substance related disorders, right? So, some of you may want to work in a rehab type setting, which is great. People need clinicians to want to work with them. Some of you want to work with an inpatient setting, outpatient setting, meaning like intensive outpatient or things of that nature. Some of you may have struggled with substance abuse or have loved someone that has struggled with substance abuse. We know how debilitating that can be, how scary that can be, how it affects the family, how it affects the individual, relationships, job. Usually, those are some of the questions you're asking clients. Like, some people are in denial of their addiction, and if it's caused them to lose relationships, a job, maybe make questionable decisions because their choice was for whatever the substance was. It's a way to kind of navigate, like, is this a problem, right? Like, what have you been willing to sacrifice for the substance? And addiction affects all ethnicities, all genders, all socioeconomic backgrounds. No one's above having a problem with addiction. And addiction, nowadays could be so many different things, right? We know, obviously the basics of drugs and alcohol, right? And as we know, there are so many different types of drugs out there. And then you throw in the whole legalization of marijuana, at least from a state level, and it's navigating like what's too much use, right? Like alcohol is legal, but it becomes a problem when we're overusing. And, a person shouldn't have to smoke out every minute of every day in order to function. I would say that's abuse of a substance. Now, people may choose to use it recreationally or choose to help them with pain or choose to help with sleep or anxiety or whatever, but it's used in like doses for appropriate times, or recreationally for appropriate times. But I've had clients who really struggle with cannabis and they smoke before everything and anything they have to do, which is not healthy. Food can be an addiction. And honestly, one of the hardest addictions to beat is a food addiction because you need food. We don't need drugs, we don't need alcohol, but we need food. And that is an addiction people have. Sounds strange, but it is. There's things like Food Addicts Anonymous. We have issues with technology. So, an upcoming, I know in Korea, they've done a lot of studies on technology addiction, social media addiction, addiction to the phone, right? And we see this with like a lot of our young people and even us, like what we do with our time when we have free time and how we spend it. Do we spend it doom scrolling, all those kinds of things? So, there's a lot with addiction. And I think no matter what, whether you work in an inpatient setting or you work as an individual clinician somewhere, you will come across people who have either struggled, know someone that struggled, currently not struggling. So they're sober, they have sobriety, trying to stay sober. There is just somebody is in probably that stage that you'll come across. So it's very, very common. So many people regularly use substances that affect their behavior. So alcohol, nicotine, caffeine, some sort of morphine. Substances used that cause physical, psychological, social, or other harm may be a substance use disorder. So even with pills, we can be prescribed pills, right, for pain, um, anxiety, things of that nature. But these kinds of medications can be abused. I don't know if you've watched any of the Netflix shows. They were very, very, very overwhelming. And just talking about like oxycodone and like the pleasure pain principle, and how the creators of the drug knew people would kind of get hooked to it, and then used um used of course their people who sell the drugs to really push it, and doctors were really prescribing it, and then people were getting really addicted to it. And then it was like a whole pandemic across the United States with people really struggling with oxy addiction. And so that's something that it can be so hard, because again, it's prescribed. So the assumption is it's safe, and anything in excess is not usually good or safe. Okay. Um, so substance use exists on a continuum form from normal to mild to moderate. Concerning to substance use disorders are less or more severe. Each level has emotional, cognitive, and behavioral characteristics. So again, with drinking, it could be basic, normal use, recreational use, not drinking to get drunk, not binge drinking, just I have a drink here and there, whatever. Moderately concerning behavior might be regularly drinking alcohol heavily and occasionally missing work or school because of it. So again, like missing out on your life due to the addiction. Behavior associated with severe disorder might be frequent intoxication or loss of job or relationship because of use. So it's cost you something. This also ties into like DUIs. Anytime you've gone to jail due to the disorder, maybe car accidents, right? Some scary things that can happen while under the influences, right? So we're talking about some features. So a substance use disorder, impaired control, psychological dependence, social impairment, risky use, and tolerance or withdrawal. So like, as we know, as you use more substances, your body builds up like a tolerance to them, which requires now more of it. So someone might start off drinking and they're like a lightweight, as they would say. Then as time goes on, and their addiction grows, it becomes harder, right? Harder to get that same response you had the first time. And so therefore you need more. We see this a lot with drugs. A lot of times people are chasing that initial high. They can never get to it. And so they use and they use and they use, looking for that high. And it's never the same, you know? And as we increase the amount of substance we're using, the dependency becomes worse. Getting off of it becomes harder. There's a lot of drugs out there where it's really difficult, and alcohol abuse. When someone's been severely dependent, you can have seizures as a withdrawal response. You can get very ill. And need a medical detox, right? So needing to be underneath a doctor's care in order to properly get off the medication. Even things like methadone, which they've created to help people who use heroin to get off heroin, but methadone itself has a level of a substance to it. And so then you have to figure out how to get off methadone. So, it's a slippery slope with a lot of these things. It's very hard. That's why medical doctor's care is so important. But this is what makes substance use so scary and like such a long road. So intoxication and withdrawal. So intoxication usually is reversible condition brought on by excessive use of a drug or alcohol. Sometimes that is medical, like I mentioned, seizures, things of that nature. The person won't have this forever, but it's just for a season while they're getting off the substance. Withdrawal is maladaptive behavioral changes when a person stops using a drug. Withdrawal may be mild or even life-threatening, like I mentioned. It depends on the substance, how the withdrawal symptoms might be. So depressants. So alcohol is a downer. It's a depressant. It inhibits the GABA system and has it has an effect on behavior. Alcohol effects closely relate to blood alcohol level, Chronic heavy alcohol use raises risk of physical and mental disorders, including cirrhosis of the liver, which is not good, and it's not pleasant to watch someone go through. Obviously, fetal alcohol syndrome is the result of being in the womb while someone's drinking. Stimulants are things that kind of make you up, right? So you think of uppers. So caffeine, nicotine, cocaine stimulates dopamine, norepinephrine, and serotonin symptoms, and amphetamines primarily increase dopamine and norepinephrine. I'm like probably not saying that right. I'm so sorry. So when you think of like meth, right? Meth is an amphetamine. This is why it's hard to buy antihistamines over the counter, because people use it to make meth in their like basement or whatever. We have to use our driver's license to get cold medicine. But that's an upper because it's going to speed you up. You're like for people who are on drugs like cocaine or meth, it's like they can feel like they've been up for hours, like doing something because they're like, go, 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 go. It's like time doesn't exist almost kind of. It's interesting. Whereas with alcohol or other drugs like marijuana is a downer. You're not going to have that high, like kind of like speed or shaky, hyper kind of response. It's going to be a different kind of response. Opiates, we see those a lot in pain pills, morphine, heroin, oxycodone. I don't know if Vicodin has like opiate is, I know Vicodin's addicting. So I would assume opiates include Vicodin, Norcos. There's some other really big drugs out there too, like pain kind of medications that can be abused. And then hallucinogenics cause symptoms of psychosis, such as hallucinations, disorganized thinking, peyote, LSD, Molly, things like that. And like I mentioned, marijuana, THC's in it. Yeah. So, and then inhalants, that's like when people huff on aerosol things, like get high from that. Steroids is considered a drug. It affects your whole body chemistry, can have rage. It affects your body deeply. Not good. Not good. So, so alcohol and tobacco use is common in the United States. About 55% of adults use alcohol in the past month. About 22% use some kind of tobacco. About 14% of American adults used illicit drugs in the past month. And the prevalence of any substance use disorder is 14.5% for the past 12 months. Substance use disorders are more commonly diagnosed in men, higher among American Indians, Native Alaskans, often comorbid with other mental disorders. So I see a lot of, this isn't to scare anyone, but I see a lot of minors who struggle with ADD or ADHD, and they've turned to marijuana to be a way to cope with their ADD. And as a result, it's not good because they utilize it quite a bit. So like, for example, with that scenario I just listed, you would have someone who has ADD and they then have a substance use disorder, right? You could see that with depression or anxiety with a substance related disorder. You just have to remember when you're trying to navigate the criteria of which one someone fits in, that sometimes if they, for example, are on drugs, maybe they don't qualify for a certain diagnosis because the psychosis or whatever's brought on because of the drugs isn't necessarily because of the disorder, it's because of the drugs. And so it could be kind of confusing. I think a lot of people sometimes are misdiagnosed bipolar when it's really like they're on some sort of substance, and that alters mood and shifts in behavior and all those kinds of things. And the hope would be once someone got sober, they wouldn't have those same kind of symptoms. But I do see that a lot where that label is put on someone, and I don't necessarily think it's a great fit because the person has been struggling with substance abuse. So social discrimination may be faced with respect to employment. People may not want to hire you if they know you have a problem. might be hard to get housing or rental property. They might feel rejected. There's some stigma and or isolation that comes because sometimes people who have been addicted to things like burn people, not like not literally, but like figuratively, like they burn people and people get hurt and they just don't want to put up with it anymore, you know? And so that's really hard for people to face. There's a lot of shame, especially when someone gets sober. There can be a lot of shame attached to addiction. And so that's something we have to work through with our clients because that could limit them and then cause them to turn back because they have to make amends. And that's why part of the 12 steps is making amends, is talking to the people that you've hurt or betrayed in the process of the addiction so that you can move forward and there can be forgiveness and there can be healing. There's so much healing and freeingness, that's not even a word, but being free when someone's able to feel forgiven, one, and mostly two, themselves. That's sometimes the hardest person to forgive, and be able to move forward. So again, like there could be a lot of hurdles someone may face, like once they do hit sobriety and they realize like, oh my gosh, this is what's been going on. And so that's where therapy is really helpful as a way to work through some of the things that the person experienced. Genetics, heredity plays into a role when it comes to alcoholism. It tends to be, for other substances, hereditability appears strongest for dependence on cocaine, opiates, and nicotine. I think sometimes we see generational curses with addiction, and there's like a compulsive kind of behavior to be addicted to something, regardless of what that could be. Like I said, it could be very varied. But it affects our brain. It affects like our dopamine levels and what comes out. And so that's why it's so important. Like if families have a history of addiction in them, to be conscientious and very aware of what a person subjects themselves to, because this can be very detrimental for them. So again, when we start using things like drugs, it can affect our brain and how our brain processes things. It can bring on other mental disorders such as schizophrenia, things of that nature. Very, very serious stuff and very scary. And so patients really need to be careful when using these substances, because you don't know if you're going to unlock something that maybe is in your genes, but maybe wouldn't have come out unless somebody would have started using something. And so not to scare people, but it's just the truth. There's a lot that happens as a result of using substances that we're not supposed to. So just things to be mindful of. Okay, so now we are going to talk about sexual dysfunctions, paraphilic disorders, and gender dysmorphia. So you will talk about some of this more in Human Sexuality. And a sexual addiction is also one of those things that creates problems in relationships, costs the loss of a job, affects your brain and neurotransmitters as far as like needing what you get from having the addiction, as far as like a dopamine release or things of that nature, and then needing that release more and more and more. So sexual functioning exists on a continuum. When sexual functioning becomes persistently problematic, it can be a disorder, and that is known as sexual dysfunction. Sexual dysfunction is a disturbance of the normal sexual response, may be lifelong or acquired, may be mild, moderate, or severe, must be considered within the context of other factors that might be relevant to the cause and treatment, such as relationships, culture, religion, and medical factors. Problems must persist at least 6 months and cause a lot of distress. So male hyperactive sexual desire disorder, lack of hypoactive. So hypo is different than hyper, right? Hypo is, so there's a lack of desire, there's a lack of wanting to have sex. female sexual interest arousal disorder, also known as female sexual arousal disorder. So there's a lack of interest and there's a lack of arousal in most sexual encounters, which may include reduced physical sensations. Erectile disorder happens when there's a problem maintaining erection. Female orgasmic disorder is a delay or absence of an orgasm. Delayed ejaculation, so there's an absence of ejaculation when with a partner, and premature ejaculation is exactly as it sounds. Ejaculation happens very quick and very soon after penetration. And then pelvic pain disorder involves pain during penetration or a fear of pain, which then causes the tensing of muscles, which then causes the person to be even in more pain. Okay. So general sexual problems or a lack of interest in sex, difficulty reaching orgasm are common, which is true. In women, prevalence rates vary from 33 to 35% as far as arousal or desire, arousal disorder, 21 to 28%, orgasmic, 16 to 25%, and pain, 5 to 22%. In men, the prevalence rates vary for problems of desire and interest, 15% to 25%, erectile dysfunction, 1 to 10% in those younger than age 40 years, and then steadily increasing ejaculation dysfunction, 1 to 10%, an orgasm, 2 to 8%, and pain, 16.8%. So what's the stigma? Stigma can be quite powerful, linked to denial and failure to seek treatment. Stigmas can affect men and women. I think it causes people to not get help because there's, again, shame and embarrassment. Shame is one of the biggest binding, locking down feelings for people. And I think that is why clients often don't get the help that they need. So there can be medical problems, substance abuse to mask anxiety, distancing self, relationship problems, personal history, knowledge, cultural risk, beliefs about what constitutes a dysfunction and what is important about sexual activity across cultures. So, trying to hone in on the individual, like this is something that can be worked out with as a couple, or some of these things can be worked out individually. I think always getting a medical examination to make sure there's nothing physically going on that's affecting sexual arousal. For example, as time goes on, women develop menopause, which does affect sexual desire, vaginal wetness, things of that nature. So it changes sex. As men age, that's where we could have an erectile problem. Also too, you just want to make sure like things are okay with your blood pressure and your heart and all that stuff. So when someone's having something new happen to their body, always suggest like, hey, when's the last time you consulted a physician? Wouldn't it be a bad idea to consult someone? Because again, you don't want them to be having some sort of other issue and we missed it because we didn't encourage them to go see a doctor. So prevention typically focus on relapse prevention with couples. So help couples continue practice physiological treatment techniques for sexual dysfunction. And so you could have them continue in something like sensate focus where, they work on like being close to one another, maybe without penetration. Sex is a big form of communication. If we're not communicating about, our day-to-day lives, we're probably having a really hard time communicating about intimate experiences such as sex. And so that's something to be aware of, like with couples, that, they just may not be comfortable talking about it. Trauma is a big inhibitor for sex. I think when people have experienced some sort of sexual trauma, whether it was childhood trauma or something as an adult, that gets in the way of their sexual experiences and creates an issue. And sometimes it's hard to talk about those things. And so that could be something that's going on that needs to be addressed, a lot of different situations that could be causing the problem. So questionnaires, this is how we assess, self-monitoring, assessments, interviews, different treatments. So medication, implants, lubricants, hormone therapy, physiological treatment, education, psychological treatment, education, stop start procedure. Stop start is what's helpful for erectile dysfunction. So those are things that a person could do. I think even just getting a person comfortable with their body. Sometimes people have grown up in very sheltered or very closed homes where they didn't talk about their bodies. And some of what could be the problem is just a lack of awareness of how their body works. I think psychoeducation is very important, obviously in an appropriate fashion. But for clients to be able to better understand what's supposed to be happening within their bodies, for them to get the outcomes that they want. Okay. I think it will improve relationships if they're working on the intimate life of the intimacy between themselves and a partner. So things to be mindful of. Okay. What are paraphilias? What are they? Many people have unusual sexual fantasies that are harmless and do not cause problems. Similarly, unusual sexual behavior often cause no harm or distress. Some people experience sexual fantasies that can become quite distressing, central to their life, or linked to illegal or harmful behaviors that interfere with work, concentration, or regular sexual relationships. That is when we have a problem and a disorder. Now, fetishes, you'll get into this more later, but a fetish is something like, as long as two consenting adults are okay with a behavior that's happening in their bedroom, assuming it's legal and ethical, that's totally fine. That's their fetish. That's what they want to do in their bedroom. That's fine. When it's a problem is when one partner doesn't agree with that fetish, right? That's when it can become a problem. Also, too, if they're doing something illegal, like there's a minor involved, something that would be inappropriate or illegal involved, that's when we have a problem and maybe moving into some sort of inappropriate disorder. So paraphilic disorders, exhibitionist, that's a person that's wearing the long straight jacket and just exposes themselves. Fetishistic, non-living object or non-genital body part. So again, like enjoying having some sort of relations with someone who doesn't consent. Pedophiles, obviously children. So S&M and sexual sadism, humiliation, or to others. Now I will say S&M, that's what they call it. I mean, if it's mutual though, like unless like you kill someone, which that's a whole other thing. Unless you murder someone as a result of like your sexual behavior. I mean, if you're two consenting adults wanting to like beat each other while having sex, it's kind of your personal prerogative. However, this is a problem if someone's doing this without someone's consent or without someone being aware it's happening to them, which are unfortunate things that happen with like drugs and putting in people's drinks and things of that nature. Like I didn't consent to this kind of behavior and it happened to me while I was out of it. Those kinds of things. Okay. And voyeurs are like basically watching people get undressed, right? Like that's what happened to, I think it was Erin Andrews, right? The guy was peeping on her through like the walls of her hotel rooms, super creepy. Paraphilic interests that do not rise to the level of a formal mental disorder are prevalent in the general population, especially for people with voyeurism and fetishism. About 60% of men and 35% of women have voyeuristic desires. About 40% of men and nearly 50% of women have fetishistic, I can't say it right, fetishistic interests. It's quite high numbers. Let's just know about the prevalence of paraphilic disorder, since the behaviors are usually secret and really brought to the clinical attention. Paraphilic disorders are more common in men than women. Voyeuristic disorders, 12% of men, 4% of women. Exhibitionist, 4% of men, rare in women. S&M, so 2.2 of men, 1.3 of women. Sexual sadism disorder, 2 to 3%, mostly in men. Pedophilic disorder, 3 to 5% in men. And transvestic disorder, 3% of men. So here's some risk factors. Genetics. Um, Again, if someone, it's in their family to have some sort of addictive quality, this is just where that went for them. Environmental risk factors, family contributions, learning experience, cognitive distortions. Again, culture and evolutionary factors. I think culture plays a huge role, again, with communication about sex, communication about what's been going on in regards to that for a person's whole life, even talking from puberty to adulthood. If like we're not in a household where we have open conversation about things, it's going to cause some issues, even for a grown up, um yeah, this is all very interesting information. um and there's not a lot of information out there for prevention of someone with struggling with paraphilia. um and it can be really, really hard, especially as we work with people who will be suffering from some sort of level of sexual abuse, I'm sure, from one type or the other. And then you have a whole other population that needs to be treated that maybe is the perpetrator. And so just being conscientious of that as you work with people, not to judge them, see them for who they are, and try to be as understanding as possible, not again being okay with the behavior, but trying to understand people and meet them where they're at to try to navigate, where does this come from? Like, how did this come about? How did you end up this way? Those kinds of things. I hope you guys have a great week. I thank you so much for your time.